And now I'll hand over to Shak, Neil, and Sivakumar.
Okay, Inga, thank you very much. And welcome to everybody once more. Welcome, Neil. Haven't seen you for a while. And you're looking very well. And I think Shiva is ready for us. Shiva.
Hi, Shak. It's nice to come back again. And actually, a lot of cath lab people here are very happy to know that Neil has joined this session. Neil has been part of this organization for many, many years. He used to come every year for all the ACT sessions, and many of the old cath lab staff fondly remember him when he used to come and do a lot of cases during the months of June, July, and August. Neil, welcome to you. And
thank you, Shiva. Please pass on my best wishes to everybody there.
Yeah,
I think you've taken over a fantastic group of people and a wonderful cath lab with a great work ethic, and I'm sure you're teaching them a lot, and I'm sure they're teaching you a lot too. So
yeah,
please,
sure.
Best regards to all of you there.
Yeah, before I go to the PowerPoint, I want to tell you one thing. Ajit and Ravi, they specially told me that they should convey their special regards to you. Yeah, the Sister Teresiamma, she actually pumps in inside and says, hi, this is hi to Neil.
Hi, sir.
Hello. Good morning. Good afternoon. Sorry. Good afternoon. Good evening. Good evening.
Thanks a lot. Actually, there are so many fans for Neil here in this hospital, and so it's quite nostalgic to know that Neil is moderating this session. Can I have the PowerPoint, please?
Shiva.
Yes.
Better get on with it.
Shiva, you can have Neil. We'll send him over to you. You can keep him.
Okay. PowerPoint, please. This is a 31-year-old male with tetralogy of Fallot who had intracardiac repair in 2007. A bovine pericardial patch closure of the VSD was done, and there was a pericardial patch augmentation of the RVOT. He was identified to have a small residual VSD. He was lost then for many years. He remains asymptomatic, but he has quite a large heart now. His LALV was very dilated because of the residual VSD. Next picture. This is a CTR showing around 60% with plethora. Next. ECG showing the usual right bundle branch block pattern and a left anterior hemiblock that is commonly seen in tetralogies. Next, LALV was dilated, LV z-scores were coming to 3.5, and the LV was substantially dilated. There was the bovine pericardium that was used was very echogenic, and hence it was not giving us great pictures. However, we thought that it is somewhere around 9 millimeters. Show the previous picture. Show the previous slide. Yeah. So we can appreciate here this is a short axis view. A very calcified looking, thick, echogenic looking pericardial patch, and on the 10 o'clock position there is a 9 millimeter residual VSD. Next. And so it was abutting the aortic valve. There was a trivial aortic regurgitation. Next. So this is a transesophageal echocardiography. We can see that it is below the right coronary cusp. There is a color flow at around 9 o'clock position in this view. Next. This is the ventricular septal defect. We are measuring around 9 to 10 millimeters. Next picture. Next. Okay. So we did a QP-QS today just prior to the intubation, and the pulmonary artery saturation is 92% and the mixed venous saturation is around 80, giving a QP by QS of 2.2:1. The pulmonary artery pressures were normal. We got little bit of LV angiograms just prior to this. Show the first LV angiogram. If you show the first frame, a little bit of calcium is there, even though it's visible to us very easily, but I don't know at a far distance whether you will be able to see. The bovine pericardium is showing some calcification. It's like a pouch, and on the superior edge of the pouch there is a residual VSD which is close to the right cusp. This is in a 60-20 projection, LAO. We wanted to separate out the VSD far better, so I did a couple of more angiograms. Next is 45. Here again, freeze this picture. Go to the next frame. Next frame. Okay. So there is a VSD that comes off. There is a superior limb that goes and hits against the right ventricular infundibulum, and somewhere it stops. But inferiorly there is a pouch that comes down, keep running now, which is parallel to the pericardial patch. Can you freeze it now and show Prabhu? Okay, show frame by frame. Okay, see
we can see it nicely. You move on.
Oh, thank you, thank
Very
you.
nice angiogram.
Thanks a lot. Okay, so it's a jet that is directed a little inferiorly. Next picture. So this is at around 45. Like basically, I wanted to see whether there is an aortic root distortion. So I put in the catheter into the right sinus and made an injection. There is not much of right coronary cusp deformity. There was a very trivial leak on the echocardiogram, not much visible on angiography. Next. And this is the last picture that I did, which probably showed the VSD better. 76 LAO. Freeze it. Okay, go back. So this was yeah, residual VSD that is coming off just below the right cusp. It hits against the RV anterior wall and gets directed inferiorly, 90-degree turn, and then it's filling the right ventricle. As I mentioned earlier, the QPQS is 2.2:1. I exchanged it into the pigtail into a right coronary catheter. Next picture. What happened was the right coronary catheter, as I was just gently torquing, it walked in into the VSD. So I didn't want to again cross it in front of everybody. So I just stored this fluoro. This is where now we are. We have yes.
Just let's ask some of the panel about if they have any concerns about the location of the VSD and how they would go about it. Tin first. Are you happy with the pictures you've seen, the rims and
show the previous picture.
Neil, I checked. It's very complicated morphology. I think it's a multiple A6 and very close to the aortic. It's a subaortic valve. And really, for me, the morphology until now is not so clear. I think
show the VSD. Yes, Tin, we will show you again. Show that
you can put a sheet and do angio again. Maybe we can get more information about the morphology.
Okay, I'll do that.
And Warrican?
Yo, Jack, thanks for having me. And hello, Neil and Shiva. Again, you know, really challenging anatomy. Again, I would emphasize what Chen mentioned. We need to put the sheath in and then we do angio. But in this particular case, I would prefer to put the sheath into the left ventricle. That's because it's very marginal area that we can deal with when we you know, deploy the device. So I probably we will put the sheath into the LV and then we do angio and then we see again. Okay. How does it look?
And Amitabh, any views, any thoughts? Amitabh, are you there?
Yes, Amitabh, you're muted. Can you unmute your?
Yeah. My main concern was the distance from the aortic valve.
There was no
distance of the VSD from the aortic valve, because it would particularly some other people would have been slightly more useful to study the distance, because I was really concerned about the.
Amitabh, the distance in metric system is 0.
0, yeah.
So Shiva and the rest of the panelists, there's a question from the audience, and they would like to know whether you think it's a good idea to cross it from the right side, from the right ventricle.
Actually, can you show that same picture, 75-20 again? Just watch this image, the previous one. See the complexity of the entry. We are having the VSD course immediately below the right cusp, initially taking a trajectory towards 9 o'clock. And then makes a turn inferiorly to 6 o'clock, and then it exits. So I am not very confident I'll be able to cross it so effectively. I'll be wasting a lot of fluoroscopic time.
Okay. Let's keep moving then, Shiva.
Yeah. So what I'm going to do is I'm going to exchange this. I agree with the points raised by Dr. Varakan that it will be nice to get it the sheath into the left ventricle if possible. Varakan, what sort of device would you think about?
Well, that's very challenging question you asked me. You know, at the moment I cannot decide until I see the angio, but likely because there is no rim at all underneath the aorta. So if you have eccentric device, that probably will be the one, but you know, it's not that stable because it's long tunnel. Then I would think about perhaps MF4 or the vascular plug at the moment.
Okay, I agree that actually an asymmetric device, the original Amplatzer perimembranous VSD, is possibly a good idea in the presence of absence of aortic margin. Now the other two devices that you were mentioning will have a little bit of artery forceps, will have a little bit of protrusion into the aortic valve. So
yeah, totally agree, Shiva. So that's why I think we will decide again after you do proper injection and then we
let me pick on Tin. Tin, options of device. I know you said anatomy needs better definition, but what are you thinking in terms of options for devices?
For me, the best device for this morphology is the BFN coil. But in case he doesn't have the device, maybe ideal one also okay. But the device should be put back inside the defect. And the device, the left side, this of the device should parallel and underneath the valve, and so we can avoid the aortic valve problems.
Okay, all right. So Shiva,
we don't have a PFM coil. Neither do we have a great experience like Dr. Tin with the PFM coils. However, we have used a lot of the old generation Amplatzer perimembranous asymmetric device, and rotating it around and getting the platinum marker towards the left ventricle, and in some sense it possibly is a good idea, because here we are secure with the membranous septum. Probably the heart block problem is not there, so we maybe if you are able to get the asymmetric device perfectly positioned, that may be a good option.
Okay, so Shiva, let me just ask Amitabh again, in terms of what other devices are available in India, for example. Amitabh, there's zero rim, so there's no rim under the aortic valve. So what are your, what would you be thinking in terms of what device to use here?
I'm not able to hear Amitabh.
No, we can't either. Are you still muted?
There's a question as well suggesting the Koner, the MFO LifeTech device, whether you consider this an option.
Okay. Amitabh, go ahead.
Yes, sir. Good afternoon, everyone. Good afternoon, everyone. So the commonest ones which we use under these conditions is a one-sided device, because to spare the other structures, there's an ADO1. But I guess here the aortic rim is 0, as you were saying.
Go to the
asymmetrical device would be the most useful one here. Though I should say that it is not easily available at all centers. We have to order it previously.
Which device? Sorry,
Amitabh. 12 millimeter, open it here.
The other
10 millimeter, open it here.
Pardon?
10 and 12.
Which device were you saying? I didn't catch it.
So the asymmetric one, the asymmetric perimembranous device.
All right.
And the other one, recently the LifeTech company has also come up with one. And the MFO device, which Dr. Tin was telling, probably I wouldn't prefer the MFO here because it's a double disc, and also the aortic rim is almost 0, as you said. So probably I wouldn't be so safe to consider the MFO under this condition.
Okay, I notice Alan Fress has his hand up. Perhaps he has a question. Alan?
Yes, thank you. Well, I was just saying that for all these devices, I prefer to use the retrograde approach because it is obviously shorter, simple, and it is possible as if you use a symmetric soft device, which is what I always use in these cases. But it would be interesting, it's maybe another debate. One of the reasons also is, even if it is not the case of this defect, many of these outlet or perimembranous defect has also inlet extension. And then when you go retrogradely, you have always a small risk to compromise the function of the tricuspid valve, whereas retrogradely you don't have this risk.
Thank you. Thank you, Alan.
show
So,
the top.
Shiva, we can see the calcification a lot better now.
Yeah. Actually, I'm trying the old noodle wire shack in order to get it into the left ventricle. And once I get it into the left ventricle, okay, now.
While you're doing that, Sebastian makes a comment that the MFO device can be delivered by either retrograde or antegrade approach. I just want, may I make a comment, Jack, please?
Yes, please.
Yes, go ahead, Neil.
Shiva, you're doing a nice job. We'll try not to distract you, but the calcium is worth just putting in the back of your mind, not because I think it will interfere with your catheter manipulation so much, but that if you don't get a really good seal with your device, the combination of residual flow, metal, and calcium does increase the risk of post-implant hemolysis. So just put that at the back of your mind, because if you have residual flow, it's worth keeping the patient in hospital and just being sure about that.
Okay, yeah. I do agree with you, Neil. In some cases that residual leak will be very annoying. Actually, what happened now, as you are observing, I couldn't get my
sheath.
I couldn't get my sheath, so now I'm again going to retry. Leave it.
Looks nice position now. What do you think, Tim? Good position for you?
I think it's very difficult for advancing the sheath into the left ventricle due to the very sharp angulation. And we want to get the best image when the sheath inside the left ventricle. But maybe it takes time and it's very difficult. Siva, you can do angio with the sheath inside the sentinel or the
internal memory artery catheter.
Yes, I for a very long time, fortunately, I'm retired. I haven't closed the VSD for years now, but I used to just deliver from the ascending aorta. I'm trying to think who taught me that. Might have been Horst, I guess. But you just push out a little olive of the device and just bring it through the aortic valve, protruding from the sheath, and then let it sort of settle in the left ventricular outflow.
Get a wire.
The problem in this position of the VSD is that you haven't got enough support when you pull the sheath back to just below the aortic valve. It pops back into the right ventricle rather than being
It's difficult either way, but yeah.
So now what? Since as pointed out by Tin, the sheath is quite rigid. And so what I am trying to do now is, I am getting an internal mammary artery catheter out, and now I am going to pull back my sheath. And
really an idea, Shiva.
Now, Warwick, you don't know what he's trying to do yet.
If I guess you try to put IMA into the LV and then use that as a guiding catheter, wire.
Yes.
It's a nice
I haven't tried that before, but that's really an idea, Shiva.
Yeah, great idea.
Yeah. If it works.
Just slip it back again into the
RV.
Okay, again get the dilator for me. Get me the dilator, please. Don't drop it. Get the internal memory again ready, sister. I will just get the dilator, go inside, and then, yeah. As it's I'm finding the rigidity of the sheath. This is a braided 10 French sheath, and so it is. The wire came out. Holding.
You almost want to kink the wire and push it downwards
This is a noodle. This is a noodle wire shack, and
so that won't kink.
Yeah.
Anybody else have suggestions?
I want another artery forceps.
Shiva.
Yep.
If you want to go to the LV, maybe you keep the dilator inside.
Okay.
Yeah, keep the dilator inside and push everything into the LV. The dilator, you can change the direction of the sheath. Without the dilator, you cannot.
I first tried it tin. Now that you have told me again, I will retry. The dilated aortic valve, the aortic annulus, is not making the wire fall freely into the LV. But let me see.
Alan Fresh, you still with us? Any suggestions?
Yes. Well, again, this is I don't have too much well, I do this technique only for muscular VSDs, so I don't have a technical suggestion here. But let's see how it goes depending of the device in implantation. I'll be happy to comment at this time.
Sebastian?
Yeah. Another option we use sometimes for muscular VSD in small children is to come from a transeptal approach through the left atrium and then the left ventricle, and then you can
get me again internal memory artery catheter.
A transeptal atrial approach or transeptal ventricular approach?
Transeptal atrial approach.
Yes.
Then from the right to the left atrium, then you go to the left ventricle. You can cross the VSD from the left ventricle and do the loop again, but directly to the left ventricle and not to the aorta.
Thank you. Shiva, did you hear Sebastian's suggestion?
Yeah, it seems a little bit more complex to me, Neil. So I'm going back to that internal memory that I was originally trying. Zishan, can you come here? Don't allow it to see the.
We've also got a suggestion from Mahmoud Nada, who's suggesting a stiff terumo next to the noodle wire into the LV and then try and change over the catheter. I haven't quite understood that, I don't think.
Yeah.
The other option, Shiva, is once you've got your sheath in the ascending aorta, to do an LV angio just to get better anatomical details of the VSD before you try.
Yeah. True. I am planning to get another angiogram with the sheath, but now for that I have to get the sheath.
We've lost you.
Yeah, we've lost Shiva.
Can you hear me now?
It's rare for him to stop speaking. So. Yes, we do intermittently.
Okay.
What were you saying? Sorry, Shiva.
I wanted to get my sheath across into the left ventricle, but now suppose if I am not getting it, maybe I will try to see the plan was to try an asymmetric device initially. However, now that I'm facing technical difficulties in, I might think about the technique that Tin had done and Neil was telling, form a tulip bud of the ADO device and then bring it back. So now what I am going to do is I am going to accept this position. Under transesophageal echocardiography, try to bring back a device. We measured around 9 millimeters, so I will try with a.
Shiva, please, if you can do angio now.
Yeah, okay.
LV.
Okay. Yeah, so can you. I have to come out of the wire loop. Okay, I'll get out the wire. Can you get me the pigtail again? Go with the pigtail. And sister, get me the wire. Get ready for an angiogram, that same 75 Show me, okay. Oh, okay. Wait. It's getting king.
Whilst you're doing that, Shiva, how does the VSD look with the sheath through it on TOE?
Can you try on a TOE? Can you come to AP view? There was a kink in the pigtail. I'll try to rectify that pigtail. Can you come to AP? Srijak, have
Whilst you're doing that, if we see the TOE then.
Echo big. Okay, echo big and fluoro small. Okay. Show me below my sheath. Keep showing me. I have to get rid of the loop.
And so ask for comment from who's doing the TOE?
Dr. Srija.
Srija, yeah. What do you think? And if you sort out the gains on the color again, scale increase and gain down, and then tell us.
Get to the same view.
And Srija, if you adjust the scale upwards and color gain down, yeah?
Scale go to around 70 or 80.
I think you'll be fine coming from the ascending aorta.
It's not increasing.
Yeah.
Slowly, of course.
Scale is not increasing.
Neil, it's like saying that the grapes are sour. I mean, actually, I tried to enter into the left ventricle, Neil, but I failed. So now I'm going to drag the device from the aorta.
Yeah. So, Srija, what do you think of the color flow around the sheath now?
Yeah, there are some flows seen. I am not getting a proper image.
Give 30
They
ml.
are around 50% of the original color flows without the sheath.
Okay, make angio bigger. Shoot. This is a 10 French sheath Varakan. Now freeze it. I can see about. Go. Next. Keep moving. Okay, the previous frame. Previous. Little before. There is a fair amount of flow, Varakan. This sheath is 10 French with, it's a braided sheath. Externally it looks like somewhere around 6 millimeter. I am planning to take a 1210 duct occluder device. What is your thought?
Yeah, I may try with what you said first.
Say again, Varakan. Try.
Yeah, I would try what you were mentioned first. 1210. But again, it's kind of borderline to me. Maybe 1214 is safer.
Okay. 1412 EDO.
Yeah, but the point would be it looked like a tunnel now. And I'm not sure whether the length is enough or not, but we'll see. I think we don't have much choice at the moment. Tin, others, what do you say?
I think 1210 is too big.
1210 is too big? But Neil, I got a echo dimension of around 9 to 10 millimeter.
Yeah.
Tin?
Yeah, I don't think we can try with a very big device for totally closer. I think the two checks is very separate from together, and maybe we need two devices. The first device maybe 10, 12, or 10, 8 ideal too, and the second device for the upper hole maybe we use a small device ideal too. I think it's the best choice for this patient. Don't try to use very big device for only for this complicated code.
Yeah, so Tim, if you were thinking of two devices, would you then put a buddy wire along a technique as well, so that because otherwise it may be difficult to recross after the first device?
Okay, I probably what we'll do is we'll try with a 1210 first. Show that picture, last picture again.
It's a lot of AR.
There is some AR because the sheath is there, large sheath is there.
I'm beginning to think about AVP2 now.
AVP2?
That's what I was thinking.
Yes.
Alain?
Yes, definitely. I think the problem with the device you mentioned, you're going to have too much space, especially towards the aorta with the discs. Whereas the AVP2, the discs are the same length and same diameter, and then you can drop only one disc on the aortic side and the central disc and the distal disc, everything on the RV side, and usually it is very stable. You have to take at least 4 millimeter larger than the color diameter of the TOE for this. So that's probably gonna 12 or 14.
1210 device, 1210 AD01. Alain, I know that your favorite device is vascular plug. The vascular plug of, suppose this is a 10 millimeter hole and I have to take a 16 plug. It will have a 12 millimeter length between the one disc to the other disc. So, where is it gone? I want a.
Yeah, I agree. This is not, sometimes this looks a little bit ugly because you have protrusion on the RV side, but it has never caused any problem in my experience. We have had a similar, well, maybe not similar, relatively similar adult case we did 2 days ago with Sébastien, and we ended up putting 18 millimeter AVP2. But in this case, sometimes, and I can see that you have a bit of distance between the patch and the aorta on the TOE view. Sometimes you can pull a little bit of the device and then have the waste in the middle disc. But this is very rare. Most of the time, you just put one disc on the LV side and the rest on the RV side, and it is very stable.
Shiva,
yes,
you choose a device that you're comfortable with. So these were just lots of points of a discussion, I think, which
Shaq, I am actually planning to take a 1210 AD01 device.
Yeah.
Try to create a ball just below the aortic cusp and see how things are. There is some amount of aortic regurgitation now because one of my large 10 French braided sheath is passing through. So I will be able to assess the aortic valve only when I take out the sheath. As you had mentioned earlier, I am using a buddy wire.
Shiva, sorry,
yes.
Shiva, sorry, interrupting.
Yep.
Don't forget to use Trevisio, please.
Don't forget to use a?
Trevisio cable.
Yeah, I am using a Trevisio. Yeah, in fact, the last case also I used a Trevisio because all sorts of angulation it's going to be accepting. So now this is, okay, this is.
So this is 1210, is it?
This is a 1210 AD01. There is a buddy wire across.
Yeah.
And Srija, you have to show me. Now this, is the pressure a little on the lower side? Can you tell the anesthetist to just reduce the dose of the anesthesia agents that is going on, whether it is Zamdex or whatever it is?
That's a very brave statement, Shiva, to be telling the anaesthetist how to manage.
Get the anaesthetist inside the room. Tell them to cut down the gas also.
Maybe things are different in the MMM.
Yeah.
Okay. So now I'm opening out the disc a little bit.
Perfect. That's enough. Oh.
I'll get it back, Neil. And Srija, no color. I just want the device to be seen continuously.
Yeah, indeed.
Can you get some angio done now? Give about a small amount, 20 ml at 18 rate. You are ready? I'm just at that level.
Yeah, you're not far away, but you've got quite a lot of the device out. Maybe you could just make like an olive shape.
At the moment, why not try and see it on the TOE?
Yeah, that's a good idea too. That's good. I like that, Shiva. Oh.
Okay. So
probably okay.
So
what's the echo like?
Yeah, we will see the echo. First, let me reconfirm with the angiogram. Shoot one picture now.
You were so quick, I didn't
25.
see it on the COE.
Oh, sorry. Just show that fluoro again. I recorded it on a cine. Show this. I'm showing now the sequence.
Yeah.
So we just dropped in, and the disc is now just below the aortic valve, and we are in the tunnel. So you give about 25 ml at 18 rate.
Could we see echo, please?
How does it look on the echo? Yeah, echo.
Okay. Srija, now show the echo.
This is needed. Can I?
Srija, Shak, what we are seeing here is the vertical tunnel we are now closing.
Yeah.
And the disc is actually sitting on the top.
So Srija, use the cursor and point out where you
I'm
think
just trying to.
Yeah, you can see it now.
First, look at the aortic regurgitation, Srija, so that we are sure that AR is not very significant. There is some amount of
There are
AR.
2 jets of AR.
Yeah, but you've got a catheter.
I have got a catheter inside.
And there was some before as well. So.
Yeah.
The pigtail is inside, I guess. The pigtail is crossing the aortic valve.
Yes, pigtail is across.
What I will do is I will take out this buddy wire now, so that the device is able to open out nicely across, because the buddy wire may be preventing a proper.
Indeed.
Can you get the echo fluoro bigger? Oh,
Indeed, but I think the buddy wire was a really good idea in the context of the instability or potential instability of the sheath. Nice.
In fact, Warakan's suggestion of that Trevisio cable, so the Trevisio is only allowing this sort of an angle, and still the device is remaining okay. Srija, now show me the echo.
Just remind me the size of the device.
1210.
1210. This is 1210, and our echo measurements were around 9 to 10.
The device
so
is
1210
parallel
is
to
the
the
one I
aortic.
thought was a bit.
Yeah, Srija is finding problem because it is parallel to the right ventricular outflow tract. Okay, now color. It looks okay. See, the amount of RV flow is less. Of course, the calcified pericardium is preventing the color that is distal to the pericardial patch to be visualized. I'll shoot another picture now. Give a little larger volume, 30 ml at 18 rate.
Juan, any questions from attendees?
Can you go to the same position?
Not at this moment, Shaq.
Okay. So
make the picture bigger.
Sebastian. Sebastian.
Yeah, I can hear you.
Are you happy with this device and position now?
I'm very interested by the position because it's really the channel and not really the VSD that is closed. And I'm really...
well, the tunnel is part of the VSD, really, isn't it? But yeah, okay. Good
you
comment.
See what I mean? It's
Shiva,
a bit
and
below in the right ventricle. And
there's a superior...
Show the
and
picture.
I'm asking on the angio, you can see that there is
Run the picture
on the top of the device towards
Freeze
the
it.
right ventricle.
Freeze it.
You know.
Go back. See, the pouch that is coming superiorly is hitting against the RV wall, and there is no blood that is going across. Then there is that 90-degree turn and a jet that was going very inferiorly, where the belly of our 1210 device is sitting. And in echocardiogram, it looks okay. Show this, run this picture.
And on angio, it looks like less flow as well.
Yeah, even echo is not showing any significant VSD flows.
There is puffing of the contrast through the device. Make it mag, zoom it. Okay, bring it towards, or else run it. Let's see, run it.
So, Shaq, there's a question now whether the other hole superiorly should be addressed, and that's, I think, a good question.
Well, yeah, but Shiva has answered that because he says there's a pouch without any flow going through into the
Can
RV.
you, without mag, you show so that it's very even more clearer? check that a superior pouch probably is not freely communicating into the RV cavity. Let me do one thing. I will probably release the device and then make another injection. What do you say?
Sridhar, may I say something, sir?
Yes.
If you can exchange the picture to the JR MPA catheter and just selective angio just at the pouch before you release, please.
Yes. Okay.
Something on the cusp.
Something on the
cusp RCC.
AR alone, you check it, Srija. Now I have come out totally. Can you get me end hole catheter
AR
like?
is very trivial only.
Yeah, RC is okay. Can you get this guide catheter? Take it out.
Sorry, we can see the residuation on echo clearly. Maybe the echo picture is bigger, and we can check any residuation.
Yeah, echo big.
Shiva, may I have a question to you?
Yes.
When let it in place and close the upper part with the added 6 millimeter, then you have closed the total flow through the VSD pouch.
Show me the echo bigger.
There are no significant flows.
Yeah, and there's no point in chasing those that pouch if there's no flow into the RV.
Yeah, there's no flows into the
No,
RV.
I believe that pouch is almost blind, sir.
Yeah, exactly. Yeah.
Superior pouch is blind.
Yeah.
I actually Varakan asked me to do a pouch angiogram,
If
so
that's okay,
I will. No, I'll do it.
Not okay, that's fine.
I'm trying it.
I think we're making it a bit more complicated, aren't we now?
This dilated aortic root was giving me some difficulty in entering, so that means.
Is there something on the aortic valve?
Like what?
There is a mobile mass.
Is there something on the aortic valve? Some blue structure?
That's what I was asking.
Like color and show me whether there is any.
No, AR is not there, but there is some.
AR is not there. Okay.
Only the previous AR.
Okay. AR is not there. Second, you check once ACT.
Heparin is.
Okay, give check ACT and give one more dose of heparin around 3000. I gave 5000. I'm trying to come into the pouch. Can you make this one bigger, fluoro bigger? Okay. Show me the. Give me contrast in a cup. Okay, show me this. That is actually going through a muscular sleeve. As I was pushing it got pumped out. Run this picture. What do you want to tell, Srija?
No, that superior defect is there. No? So the flows are there. It has gone into that pouch, the device.
Yeah, it has gone into the pouch.
Yeah, but
I doubt whether can you get me another thermowire again? I'll try to recross.
It should have been.
Is there a flow there significant?
There is some flow.
Some flow is there.
Yeah, in a different angle.
Flow where? Through the pouch?
Yeah.
Show the.
I can only see the exit into the right ventricle.
Exit?
Yeah. But there was some. Let me just put a gradient.
So, Zishan, can you come and hold my catheter? I'll try to cross. If it is not, I'm not able to cross, that means it's muscle.
Jack.
Yep.
I think we're trying to gild a lily here.
Yeah, I think the main defect is the one where the device is, and we should make a decision about releasing that and not worry about the pouch.
I agree. Anybody got anything to say about that?
I think
Alan thinks a bigger device would have been slightly better.
Yeah, I'm not able to push the device, push the wire through that pouch, Shaq. I think it's a muscular pouch. It's not. There is not too much of lumen there. Anyway, let me again.
But Siva, even if there was a little leak there, trying to address it now is going to be hazardous in the context of your device, which is sitting nicely.
Yeah.
And you might, even if you want to address it, you might want to do that in a few weeks' time when you've got some.
Yeah, I do
Shiva,
agree.
You've dealt with the main defect, which was the problem. So, we haven't dealt with it because you've still got the device attached, but you're in a good position. Make a decision about that and not worry about this pouch. Because you don't, there's flow that you can see, which is still overspilling from through the device as well.
Yeah.
Yeah. Actually, the pouch is contracting and squeezing the contrast back into the LVOT.
Yeah.
So it is convincing for me that probably the amount of blood outside the device is negligible. So I am.
Shiva.
Yes.
Do you have an MVP? Then you can put it in over this wire, over this catheter.
Don't even think about it.
Pablo Tome is asking the technique about the body wire in the sheath and the fact that you have, if you like, two devices going through the sheath. How do you control the blood loss at the back end of the sheath? Or is it the fact that you've got enough hardware in there that it seals the sheath?
No. Actually, Neil, your point is correct. There is quite a lot of bloody field here. There is some. When I have the cable plus the body wire both going across, it is not perfectly hemostatic, and so there is quite a lot of blood loss. I do agree, and that too, my sheath was actually in the ascending aorta. So it's true that there is a. See that actually that pouch is not significant, Neil. It looks like I am.
No, I think you've done a very nice job, Siva, and you can address residual shunts at a later date. Just take care about the concern for hemolysis. And it was Pablo Tome who asked the question about leakage at the back end of the sheath. Yeah. Pablo, I don't think there's an easy way.
Shiva.
Shaq, if you give me around, I think we have around 12 minutes more. I can show one transvenous crossing of a VSD and closure in a child without arterial access. If that is okay for you, within 5 minutes, within 10 minutes, we'll try to complete.
It's 10 minutes, no more.
Yeah, 10 minutes, no more. Correct. Get me one glove, please.
And whilst you're doing that, Pablo asked that question because he saw so much blood on the groin.
Yeah. That actually, I told Shaq, I told Neil that no, I want a gown. Whenever we have a 10 French non-cook sheath, which is not very highly hemostatic, and then you have a body wire as well as a cable across, that hemostatic valve is not very good, and so there is an issue there.